Hello and welcome. My name is Philipp Lurz and I'm delighted to be here today with Felix Mahfoud. And the two of us, we will discuss today the role of interventions in heart failure. Obviously, medical therapy is the first-line treatment in chronic heart failure. What are the clinical scenarios where interventions might play a role?
I mean, there's absolutely no question that drugs work very well in heart failure. May it be patients with reduced ejection fraction, but also patients with preserved ejection fraction. We're seeing that drugs improve morbidity and mortality, lower symptoms, and improve quality of life. But even in the most recent studies, we see that the event rates remain high despite that pharmacological therapy that is available. So there is still a room for devices to improve symptoms, to improve quality of life, and hopefully also to reduce morbidity and mortality.
So clinical need and still room for improvement.
Absolutely, yes.
What sort of interventions do you see which could actually make a difference in these patients?
There are many, and it's certainly a growing field in interventional medicine. We're seeing more and more options becoming available and being tested in clinical studies. One is probably related to shunting or decompression of the left atrium in certain manners. One is an intra-atrial shunt, where you provide a volume that is shifted from the left to the right atrium to decompress the left atrium. That then should improve congestion and improve exercise capacity of patients. There are some randomized controlled trials with mixed outcomes though. Some are ongoing, and there's one device now being available that shunts volume from the left atrium to the coronary sinus, which is a completely new concept. We're both working on that study as well, a randomized sham controlled trial looking into that novel device. And then certainly neuromodulation is one, which is a new kid on the block, I would say. Not new for hypertension, but new for heart failure. I'm curious to hear your thoughts there as well. And then certainly valve interventions. You are leading that field, obviously, with many studies that you have conducted. Where would you see that, for instance, AV interventions could play a role or play a role in heart failure management?
I think it took us quite a while to prove that a reduction both in TR but also MR has implications for outcome. The question is whether that always needs to be done by an intervention or whether it also can be achieved by optimized medical therapy. And obviously when you can optimize medical therapy, then you should try that first, because you can see some reduction both in tricuspid but also in mitral regurgitation. But first of all, it doesn't last that long, and also it doesn't work in everyone. So I think there's a clear role, and the evidence supports that, of adding an intervention to reduce either MR or TR. We've seen already positive signals in terms of heart clinical endpoints in studies looking at patients with mitral regurg, secondary, functional obviously. The signals are not as strong on the tricuspid side. Not yet, because I think that there we enroll slightly too healthy patients. But the newer studies, which are still ongoing and enrolling, they enroll slightly sicker patients who are at higher risk, and I'm pretty confident that we will see a difference there. And one should always consider not medical therapy or intervention, but really see them as something, as an adjunctive therapy, where an intervention can help to optimize medical therapy, and the optimization of medical therapy will always end up with a better outcome of the intervention.
That would be interesting to see in clinical trials, right? A facilitation of up-titration and guideline-directed medical therapy. That would be a nice endpoint in such a clinical trial as well.
Absolutely. And in previous trials, sometimes it was criticized that in the intervention group, the GDMT was better. But I think this was because of the intervention, so it adds up.
Yeah, it's good. Yeah.
And then you mentioned neuromodulation. Can you elaborate on that a little bit, please?
Yeah, we worked also on renal denervation for quite some time now. I think it's in the guidelines for hypertension. There, the trials are straight in one direction, indicating that it lowers blood pressure as compared to a sham treatment. And now we're understanding, obviously, that neuromodulation may be interesting also in other indications. You are running a trial in heart failure with preserved ejection fraction. We're about to start a study where we combine renal denervation with hepatic denervation. So that's a multi-organ denervation study where you try to denervate not only one organ, but you combine two approaches with the same catheter, reducing hepatic sympathetic nervous system activity in combination with renal sympathetic
And that's,
activation.
That's in symptomatic patients with HFrEF.
I know this is in patients not necessarily with heart failure, but patients with fatty liver disease, patients with diabetes, patients with hypertension. Many of them will have HFpEF, I'm pretty certain. But this is just to elaborate on the potential future of new indications, what we're seeing. And I guess the book is not closed there, certainly. We're seeing more and more studies being conducted, starting enrollment, and that's a quite interesting field. There's another device available, which is baroreflex stimulation, which is not really picking up in terms of numbers in Europe, at least, in the US a bit more. A pacemaker that is stimulating the baroreflex at the carotid arteries in patients with heart failure. So certainly, the field is moving in some directions, and we understand that also vagal nerve stimulation, we haven't found the best solution to do that really improves symptoms and quality of life in patients with heart failure. But I guess, further down the road, we'll see more and more devices being tested in patients with heart failure too.
What do we need to see more and more devices tested, and what eventually is needed to implement it?
I think we need very strong clinical trial data, and I'm happy to see that besides renal denervation, many of the new devices are being tested now in sham-controlled trials. And this is really what we need, right? We need highly experienced centers running good quality trials with strong control groups where we can really understand what the added benefit of an intervention is, to understand what the true treatment effect of these devices is. If you don't do it in randomized and potentially sham-controlled trials, you will always overestimate the treatment effect, particularly in patients with heart failure.
Absolutely. So interventions in heart failure, clear clinical need, a lot to gain, sound pathophysiological rationale. We still need the data, but luckily there are multiple trials enrolling, and there will be much more to discuss in the future.